All right, thank you everyone for joining our series one of our competency-based focus webinars today, elevating competency-based education through simulation. I'm Will Trapowskis. I am the product marketing manager for the nursing portfolio here at Laerdal Medical. We're just going to give it a moment or two here before we begin our presentation so we can have all of our participants join. So please hang tight and we will get moving in a moment. Alrighty, so just wanted to set some objectives for today's webinar. So we would like you all to provide information on the background of getting started with your CBE journey. Also, how could you use simulation to best achieve competency-based education? And then also utilizing this webinar as a recording and a resource throughout your CBE journey. And a quick reminder as well, so please use the Zoom Q&A function, so it should be at the bottom of your screen, to ask questions throughout the webinar. There will be a Q&A session at the end of this presentation, and then also a recording will be emailed to all attendees today. Without further ado, I would like to introduce our guests. So our presenters today are Dr. Carol Durham from the University of North Carolina, as well as our very own Michael Sauter, the Chief Learning Officer here at Laerdal Medical.
Hello.
Hi.
How's it going?
Good.
Good. Thank you both for joining us today. If we move to the next slide, we have a quick polling question. I know we did ask this when you did register for the webinar today, but we would like to kind of know, to base our discussion around you all today, where is your organization in its competency-based education journey? So we have a few choices. I'm just going to read them out for everyone. So we're beginning the journey. We're started to map our curriculum to competency-based education. We begin implementing some CBE, as well as we've fully implemented CBE across our curriculum. So Carol, Michael, I'm sure we're going to get an array of different responses here, but I'm interested to see what kind of responses we're going to get, because I think it's a really interesting topic, especially with nursing and simulation currently. We probably have a pretty wide array of answers here. So we're just going to give this a second as everyone begins to select this out. It looks like the majority at 42% are beginning their journey. 32%, which is quite promising, as everyone started to map their curriculum to competencies. Some are actually beginning at 18%, and then fully implemented CBE across our curriculum is 7%. So we got some good answers to start here. And I think starting is probably a good point for this. So I know, Carol, you've done a lot of work with competency-based education. So maybe you could kick us off as to kind of what is competency-based education, and how does it apply to simulation, as well as the work you've done with the AACN?
Thank you, Will, and we're excited to be here with you today. I know that many of you have your awareness on these new competencies, the essentials that were published in April of 2021. And just to give a perspective, the last time the baccalaureate essentials were updated was 2008, and then the masters were updated in 2011. So every so often, the competencies are looked at and evaluated and actually updated. This time, instead of doing the baccalaureate and the masters, which are now called pre-licensure and advanced level nursing education, they are done together. And so the idea is that we will level these competencies and domains across from pre-licensure to actually advanced practice. So I just want to get us all on the same page as we begin to think about this. And I do recommend that if you haven't actually purchased the AACN Essential booklet or actually download them for free from the AACN website, they should be a permanent fixture on your desktop so that you can actually reference these periodically as you're working through your programs. But AACN defines competency-based education as a system of instruction, assessment, feedback, self-reflection, and academic reporting that's based on students demonstrating that they have learned the knowledge, the attitudes, motivations, and self-perceptions and skills expected of them as they progress through their education. There are 10, as you know, core AACN domains, and they're listed here, and I'm sure you're familiar with them and revisit them often. And as you know, there are numerous, somewhere over 250 subcompetencies. One of the questions that emerged from the registration was like, when is the date that I have to have these actually implemented in my curriculum? And AACN responds to that question saying, there's not actually a date, but rather get started and keep moving forward. And so this idea of trying to move this forward is what's really essential. So back to Will's kind of overarching question about this landscape of competency-based education, why now? I think that one of the things that we're seeing is that on the academic side, we really feel like we've prepared the learner to enter into practice at whatever level they're entering. But on the practice side, they're finding that they're not as ready, practice ready, as they anticipated. And so I really commend AACN for really looking at this through a different lens than historically, and recognizing that if you're wants people to be competent, it has to be more than knowing, and actually more than knowing how, but actually you have to show and do. And that comes from Miller's pyramid that I expect many of you are familiar with. And so this national push to really ask us to look at what we're doing academically and how is it landing with our learners, but most importantly, how is it preparing them for practice? And we know that practice is complex. We have some workforce issues, and all this are creating this perfect storm that we're putting new grads into this work, whether they're at the pre-licensure or the advanced, and they're needing to be ready to navigate all that comes at them. So it goes so much further than just knowing.
That was actually several, Carol. Thank you for that. So for those, and I guess you get this immediately when I open my mouth. I'm not an American. I'm not a native speaker even. So I'm a Norwegian living on the southwest coast of Norway. Been with Laerdal Medical for better part of 20, and I have an education background. So what I found it very interesting leading up to this webinar. We had a pre-chat, Carol and myself, and it seems like we share some passions for education and some of the methodologies, but also the deeper questions lying behind it or foundational to them. So just to set the stage a bit and be transparent, this webinar is not about providing a cookbook recipe on how to go from A to Z on competency-based education. That's better found elsewhere. This is meant as a conversation around some of the key themes and topics that lies at the foundation stone of competency-based education. We're going to start out pretty high level and then take some deeper dives where it's appropriate. So I'm curious as to what you just said, Carol, when it came to sort of this point in time. Could you unpack that a bit further? What is it right now in nursing that sort of sets the direction for why this is the right thing to do?
So I think that I believe that faculty and learners all intend good. And when you ask any learner, why did they choose to come into the profession that they've chosen? Most commonly, they want to help people. They want to make a difference. And I think that in education, academics have tried to get them prepared to do so. And we've done that in a way that really was how we were trained. And we have not examined, did that work or not? And we looked at, we know that lecture was a way that maybe I was educated, and maybe even you, Michael, but we know that that really is not a good way to learn because it doesn't stick. And I think that this has given us an opportunity with the revision of the essentials to look at what are we doing, where are we trying to get our learner to do, and really ask the hard questions, or are we doing that? We're beginning to have conversations with our practice partners to see how are our students entering the workforce. One of the concerning things is that many of our grads are leaving practice after 1 to 2 years. And knowing that we have some workforce issues, having people go in and be onboarded for $60,000 to $80,000 by the agency, and then to leave within 2 years is really harmful to the learner who invested time, money, and effort to get here and now leave, the agency, but most importantly, to the patients for which they care for.
Yes.
Because we need a depth and breadth of expertise at the bedside. And so we obviously need for our learners to know, but we also need for them to know what to do with that knowledge and then to be able to apply it. And I think that we feel like historically, even myself, we thought if I educated them, then I've done my part. I think now we really have to consider that is not enough. I can't rely on the agencies to pick up where I left off, which was gave them knowledge, and have the agency be responsible for the showing and the doing and the demonstration, but because they don't have the bandwidth, and nor should it be their job. It's our job as educators. So we need to educate them so they're practice ready. And that's a common word that we talk about. And as we know, we all have a different definition of that. When I say that, you see it in your head, but it might be different, Michael, for you or Will or all the attendees on the thing. We haven't took time to talk about what does that look like? Same thing
Yes.
with competency. Can we come to a kind of common language around what competent is?
And so let me dive into what you just said, which is extremely interesting. I mean, school A, school B, same street, and you walk into one, the current one, and you walk into school B, which have just fully implemented CB. At the face of it, when people walk in, what is it they see that is different?
And I'm using my imagination to
Right?
imagine, because as you mentioned, there's not a how-to yet.
Nope.
We're all kind of building this plane as we're flying it. And if you feel that way as an attendee of this webinar, you're just normal, because we are. And that's the thing that I think that's helpful. So let me just describe what I imagine and what I'm beginning to see is that traditional school A is still probably doing more lecture and assessment, that are ways that are probably testing and then assuming people know and do, and that's good. Versus B, who's moved on down the continuum, and we got 7% on this webinar who have fully implemented competency-based education. Good job. And I suspect you're still refining and evolving, but the rest of us are coming along behind, and we're hoping to learn from you and with you as we all try to do this. But the thing that I think is important is to recognize that in those schools, I imagine there's less lecture, there's more coaching versus evaluation. You did it good, you did it bad, you have to, you have to go and redo it. But rather coaching and inviting the learners to come in alongside the educator to co-produce their education, that they come with a growth mindset. And we actually have to undo some things because learners have come from an education system historically has been take the course, learn the knowledge, take the exit exam, and then sell your textbook and move on to the next course. Nursing is a cumulative profession. You have to take the knowledge that you learned today and build it into the next day and the next day. And so this idea that learners have to be active learners and not passive learners is something we have to undo. And I think that learners are very comfortable sitting back and letting there'll be a sage on the stage. You tell me what I need to do, and therefore I've been educated, at least the educator thinks you have, and then I'll go and do my best. There's going to be a lot more coaching and assessing formatively versus summatively, where we like, yeah, you did or you didn't. Now we really need to have them, you're almost there. You need to refine this. You need to do this.
And I'm going to offer some thought. With my general education background, I'm always struck with this sort of almost like a conundrum. So there's this objective competence, that there's the objective side to it, right? We measure, we see, we give feedback, we coach, and then we sometimes seem to forget the subjective side of it. And these two always meet at the gate. So this is about me feeling confident, my self-efficacy is there or not, or is low or high. And I'm curious as to, what do you think about how competency-based education somehow can make both of these visible, both the learner and for the faculty?
I think if we look at these competencies, this is a nationwide initiative. So we
Right.
actually, no matter where you land from your program of study to where you end up working, there's this expectation that you're able to do these things. So how do I see it? So I expect educators on this call know competency when they see it. And so can I define it well enough to measure it? And that's where we are now. How do we look at all these competencies and subcompetencies, define them well enough to measure it? So it's not like a checklist, one and done. You actually, when I see you demonstrate competency, and to truly be competent, according to Miller's pyramid, would actually be in practice, the doing in practice. So simulation is right underneath that with the showing how I will do it, assuming that simulation mimics clinical and is high quality, well designed according to an actual healthcare simulation standards of best practice, which are a free download as well, then I actually do have a good feeling that you can show that in practice. But if I were to go in and follow you into practice and see you do it in your clinical or actually in your job, then seeing you do it once is not quite enough. I have to have multiple measurements of you demonstrating that competency. Then you begin to see how this becomes humongous, right? But
Right.
the idea is that's actually how I know if you're competent, because I might be able to demonstrate competency in this clinical situation, in this day, etc. But the point is, can I be relied upon to replicate that over
Right.
and over? And that actually, the knowing and doing of competency is what we're after.
And this is, of course, it's going to be a journey, of course, but I'm also thinking that I see some places where I travel, people do a scenario and they do their debrief, and then they move on to the next scenario.
Mm-hmm.
And then I'm watching the students, and I'm thinking, so half of you, probably according to David McClellan's study on self-efficacy and motivation, half of you have a baggage where what you just heard tells you what you need to know and move on. The other half of the group have either low self-esteem, self-efficacy, or whatever. You heard the same message, but what you take away is, I'm not really good enough. So you're driving people up a spiral or down a spiral. And one of the things I'm hoping for with competition is that students, from a student perspective, will relevance and meaningful purpose of simulating a lot. Because it's not only about what the faculty can see, the objective side, it's also the subjective side. I need to be able to tell myself, I can do this. I'm confident, I will step forward when it's needed. Not overconfident, but certainly confident enough, sort of mixing those two together. So I think when we're trying to mix simulation into this equation, it's going to be interesting to see how we organize that. Are we allowing students enough time to simulate to also build the confidence level? Yeah.
I love that perspective, Michael, and thank you for bringing that into the conversation, because that is exactly on point. And I think that in that own time, some learners will be one and done and moving on to the next. And there are others who need more time. And that doesn't mean they're better or less better as a nurse,
Yep.
but they actually are different learners. And you overlay the emotional, the self-esteem issues that we bring to anything that we engage in. So we don't know historically what has been the experience in education for this particular learner, but all that comes to place. And one of the things I think that I actually try to situate our learners into is we use the Cambridge medical model of basic assumption, and basically say, we believe that all of our learners are intelligent, capable, and want to improve. And then I say that and the students are nodding. And I say, well, I'm going to go back and say, and wants to improve. And if you
Yes.
really, truly want to improve, then you're going to have to receive feedback. And the feedback's not, you're perfect. Because the only way to improve is actually to have not met the mark and get feedback and to grow. AACN is positioning this as coaching, that we actually can coach learners more than just one time go in, evaluate, and say yes or no, but actually look at how can we look at this individual learner, help them actually get better, and equip them actually to start doing that themselves, that they become reflective learners and they themselves are motivated to improve my best, to best my best in terms of deliberate practice, and really think, I really want to be better at this. So this idea of shifting learners from just tell me what I need to know to a growth mindset and a sense of curiosity and inquiry is what we want to move them to through these AAC and kind of building these competencies, so that what I tell my learners is that I am here to come alongside you to help you be the best possible nurse that you dream of being.
Mm.
And that's my job. And that means you have to come alongside me to do so. And it's not like I can, because I think we have this sense that if I praise students, then I'm helping them. Certainly, letting them know what they've done well, but to give them global praise is not helping them. We really have to do a critical analysis of performance and give them kind, respectful coaching to help them move from A to B. We have, if we're honest, have received that in the past. And our openness to that helps us to grow professionally. And that's what we're looking at, a future colleague, a future professional that we're just coming alongside and mentoring, coaching them into a competent nurse.
Right. And you bring up so many excellent points, Carol. I'm curious though. So with, I guess at least for the foreseeable future, the near future, there will still be admission by cohorts.
That's correct at this time.
Right. Yeah, at this time. But what you're saying, and what I find extremely interesting, is that competency-based education, in a way, is the ultimate adaptiveness of the system. We're trying to see or meet you where you are. And you used the term "come alongside." But how do you envision that play out when we're still working or admitting people in cohorts, and probably even the same cohorts? How do you see that working out?
That is the $1,000,000 question, Michael. And if we were able to answer it, we might could retire and go on the circuit and tell everybody how to do it.
Let's do
But
it.
I think the point is, for the foreseeable future, which is probably a long time,
Yeah.
we will have to admit by cohorts. We have a workforce shortage. We have not necessarily shortage, people leaving the workforce, right? So we don't have the workforce that we need. But the idea is we need to educate as many nurses as possible, as efficiently as we can. So I think that we're going to have to build in some of this. So I'll give you an example using simulation as an example. We actually have our learners complete a virtual simulation. And so when we first deployed this, we thought, well, we'll just do this with them. And then, of course, they look to us for the guidance about how to correctly complete the case, etc. And faculty care a lot and want students to do well. So we we helped them complete the case. So we drove them to the answer. But the struggle is where the learning occurs. So now we have the students complete the cases independently and then come to us for the debrief, which you mentioned. And in that debrief, we drive them to tell us what they were thinking. So when they made the error of care, they're doing their best thinking. Tell me what you were thinking. So what I have found when they begin this process with us with these cases is that they know a lot. They've finished all their kind of lectures. They've got all their content. They're at the end of their program of study. They know a lot. And I tell them, you know a lot. I know that. I know you're smart and you're intelligent. And I would do my little basic assumption. And I said, but I find that it's fragmented in your head and you're not sure what to do with it. And so the purpose of these debriefs is to uncover where you've made your errors and what your best thinking was at the moment, to kind of correct that thinking and help you then go forward with either an algorithm or an understanding of how I not only know, but now can understand and apply it in an organized fashion in the care of the patient, and then reassess and move forward in the care of the patient. So if we remember all of this, Laerdal's mission, academics mission, practice mission, is all around quality and safe patient care. And if we remember that is the goal for which we are targeting, then if we can help these learners know more about how to use the knowledge that they have to rehearse it in a simulation, which I think simulation is a rehearsal for practice, and then get feedback on that, coached on that, so that they can fill in the gaps and not be offended by the feedback, but embrace the feedback as a way to learn. So one of the things I think is helpful to understand is an example that everybody on the call will understand. We tell students all the time, do this and check the labs. Like when you give Lasix, you want to make sure the potassium's fine. And the learners will say to me, I always knew I needed to check the lab. I just didn't know why or what that meant, or sometimes even what labs I should check. So, but I'm sure the educator told them, but it didn't stick.
It didn't stick.
This is what's important for it to begin to coalesce and hang together for the learner around the care of the patient.
And I guess that's also where simulation as a sort of a way of embodying that knowledge is very relevant. But so here's and it's not a trick question. I don't have the answer and you may not either, but it's a valid question, I think. Will simulation look different when we move to competency-based education?
I think there are threads of the simulation that we're currently doing that we would augment. So yes, it looked different. I think, and we've been on this journey of simulation discovery for some time now.
Yeah.
And, I remember back in 1999 when we started, simulators became more easily available to nursing curriculum. They had been in anesthesiology and other places. But we were like, wow, this is so cool, the new bells and whistles, and we were all trying to embrace it. And for a moment in time, it became about the mannequins. And we let go inadvertently that we are the designers of the educator.
Yes.
And so the educators have to remember they are designers, like the contractor for a house, and that you have to choose the tool that best does what you need at this moment in time. And so that is what I think is really something that we did re-embrace and we need to hold on to. And I think now we're beginning to realize it's not enough to design the education, but to also now be very deliberate about coaching the learner as they interface with the education. And as you alluded to earlier, they're going to be at different points in time on different days in time.
Yes.
And so the complexity of it is that we have to be fluid as educators.
Yeah.
So when we do this debrief, it's kind of alarming to imagine that we can actually do 17 students in this room instead of 4 or 5, which is what we'd like to have. And it's because we've designed it so we break them out to the smaller groups. And it's this design that we've created. But the point is then I can dive into your thinking. And collectively, we all can hear it and grow from it. So I can ask you, why did you do X? and you will give me your best. And I know that you are intending good. You never meant harm, but in the scenario, maybe the patient died. So we need to understand, how do we not do that again? And so
Right.
we are then able to use the algorithm. Now our knowledge is enhancing, and we can now move up this thing of knowing how, and then beginning to show you that I now understand how to do this, and to do it in a way that has the outcome that I hope you hope, which is better outcome for our patients. And so I tell the students all the time, the point of all of this is that at 2:30 in the morning, when you're by yourself on the floor because everybody else is busy, and a patient in front of you just doesn't look right, how do you do your assessment to know what is not right? And then how do you apply your expertise to analyze what's going on, use your knowledge to make a decision about what needs to happen, and then actually engage a provider and or do some interventions, go back and reassess the outcome of those interventions with that patient, and then move forward in their care. I don't want you to be frozen at 2:30 in the morning and go, something bad is happening, I don't know what to do. Call a
Right.
provider, wake them up and go, they just don't look right, you need to come see them. That is not helpful to anybody. And so we equip them with the knowledge of knowing how to make those conversations. What is it you need to have at your fingertips to share? Vital signs, presentation, whatever it is, and to do it in an efficient way, because the provider you're calling is really this kind of point that they have 30 patients or more that they're caring for. And my job, and they have to understand it is their job, to get that provider on the same page as you and to hear the urgency of the care we need for this patient. So we're a collaborative team now. I'm not just a nurse. They're not just a physician or provider. We're in it for this person to have the best outcome. So then that raises my level of confidence that I'm a key hands and ears and boots on the ground for the care of this patient. And what I bring is valuable expertise to help, not to make the physician better or the nurse better, but the patient better. And we have to keep our eye on the goal that we're trying to accomplish, is patient safety.
And it's interesting, at the same time as we're talking here now, of course, and listeners would know this, in medicine, they are implementing a framework that is quite similar, the entrustable professional activities, EPAs.
Mm-hmm.
And I guess I had a chat with sort of the founder or the father of that movement a while back, Olle ten Cate in Holland. And he said, the key question is, what is it we can entrust you to do 2:30 in the night?
Mm-hmm.
What is it we can entrust you to do? So it's a different kind of question than what is it you can do here and now, but what is it we can entrust you to do? But I wanted to look back a little bit to what you said earlier, and I was particularly thinking of faculty, because in this movement towards competency-based education, with students being met where they are, allowing to progress as they master or show mastery, it strikes me as it's going to be tough or hard work for educators to keep track. And I'm curious as to where you see the use of data in this. We're living in this data age.
Mm-hmm.
And have you given any thought to that?
I think it's a golden opportunity for us to reconsider how we create and measure the metrics that we see as indicating competency.
Exactly.
And I think that there's a really great place for somebody to create an app that is on the student's phone that the student and the faculty can share. But I think that, and I imagine that it will happen. But what I see is many of our industry partners, which I so value, because your goal is the same as mine, to improve patient outcome, to prepare learners so they're ready. And I think dashboards are going to be important for all kind of ways that we can use products. and dashboards that are visible to the learner as well as the educator, so that if you're imagining you want to have a growth mindset for faculty and students, in one of the courses that we use this process I was just describing, every semester we have this quality improvement approach to it. What worked well last semester? What do we need to ditch? And what do we need to fix? And what do we need to add in? And a lot of that is the students' response and what we're seeing in their movement of how we're moving them towards this practice readiness. So I think that your question is, I believe that technology is going to be our friend because it's going to give us dashboards and tracking of metrics. I think we're not yet arrived to the best possible way. And in fact, when we get there, I'm sure that it will move to the next level because we will imagine more things that we could do this. But I think having metrics in actual, because students in this generations are in, or even in our generation, enjoy gaming. We like to kind of do our best. I mean, people do Wordle and other kind of puzzles and trying to like, can I do better than I did yesterday? And so I think we humans like to best our best. And if we can engage that, but not leave behind those who are struggling, but remember that we want to coach them in tips of how they can accomplish and improve. It is a monumental task. It's going to ask a lot of faculty.
Yes.
Because we're coming in, and some faculty are beginning their roles as educators, and some are experienced. And I think both the continuum of faculty are going to have to also engage in this growth mindset of learning more about competence-based education, learning about the principles of learning from the brain functionality, and not only education principles, but also the neurobiology of learning and how we learn and how can we maximize how we learn in the educational modalities that we choose for X, and how do we keep the learners engaged and keeping them really thinking and learning and seeing that this is not just to finish this course or graduate from a program or pass NCLEX. We are talking about saving people's lives. And we are doing that every day. And I'm always amazed when you sit down at the dinner table and you're a nurse and, you know, people are like, so how was your day, to the kids or whatever? And you talk about the day, and we don't ever say, we often don't say, I made a difference in people's lives today. We often talk about, I didn't get to eat lunch, or didn't get to go to the restroom, or it was a horrific day, I'm exhausted. But we need to start being careful about talking about what are the things that bring us joy in our work, so that we can entice others to come into our profession. Because if you always are just complaining about the things that are challenging about the job, who wants to go there? So I think we need to talk about the joy of our work. So I'll tell you an example. In 2010, I experienced septic shock. And I almost died. And the reason I didn't is because UNC Hospital had 2 nurses who were practice ready. They were in practice and they had been taking care of patients, and they recognized I was in trouble. They knew what to do. So they noticed, they analyzed the data, they were able to apply their expertise and rescue me. In fact, they led the team in rescuing me. So obviously there was a bigger team, physicians and others who cared for me, but I survived. And so I'm ever grateful for that because, and so I was passionate about patient safety. It was part of the quality safety education of nurses when it began here at UNC. But looking into the face of my own mortality, having a sense of impending doom, and then being rescued by competent and confident and expert nurses is what I want all of my learners to be able to do. And I actually end my time with them and say, I want you to be the nurses who go out there and save the Carol Durhams who are in front of you.
That's extremely powerful, Carol, and thanks for sharing. And I look at the screen now, I see Will and Rebecca, and as Laerdal colleagues, many of the listeners are probably not aware of this, but we have, of course, this mission of helping save 1 more million lives every year by 2030. But that's just a number. And so we try to, at least in our meetings here in the leadership group, we try to bring forward survivor stories. Our meeting rooms here in Stavanger, Norway, has names of survivors. So thank you for sharing that. That gave me a sort of a goosebumps moment. But sort of we're coming towards the end here of the webinar, and I'm sort of curious as to, we talked about the opportunities, the possibilities, but are there any sort of stumble blocks that we already now are seeing? Are there any divergings? Can we get lost on this track? I guess that's what I'm asking, and what could possibly lead us astray, and to make sure we stay on target.
So I think that, yes, indeed, we can. And I think that sometimes if we take what we're currently doing and don't carefully examine it and see, is this really doing what I intended to do, but rather polish it off and call it something, a new name, I think we need to be careful to really look carefully at what we're doing. Think about the neurobiology of learning, think about the ways of teaching, think about the ways of learning, that we actually can make a difference in this and assess that and coach that. Then I think the other piece is if we go back to checklist and say one and done is enough, because if we really are talking about competency, you need to see it in practice. And, it actually needs to be in practice, whether that's a clinical, you watch someone in clinical or actually in their actual job. And that's a whole nother workforce. How do we do that? That kind of thing is intense. And it has to be more than once. If you're talking
Yes.
about, I can entrust you to do X, then I need to be able to see that in this context you were able to, in a different context you were able to. And so
Yes.
I'm really looking at you being competent in using your knowledge, expertise, and applying it and reassessing it and, all those things. So what can derail us is the fear of failing, because I think that keeps us from trying. And so we have to try. And if we don't do it perfect, we learn from that and we go back and we try it again. But don't be fearful of not having it perfect or fearful that you will fail. You probably will. You're not going to be perfect in all the places you try. But isn't that wonderful that you can now examine what happened and how can I refine it? But you have moved forward. You have started. You are trying with good intent. And I think that being fearful can be a derailer, and also being overwhelmed and throwing up your hands and going, this is impossible, so therefore I'm not going to do it. So what are you going to do instead? Drop back to what we have been doing, and it knowing that it's not going to be effective. That is not who you are. You are a nurse educator who wants good for those you care for, who wants the best for those you educate. So you can't settle for less. You can't settle for mediocrity. You have to strive for excellence.
Exactly. And I think that is, to me, the core of what is happening right now with competency-based education coming in, because education has been all over the place. Education background, I mean, it's all over the place. What is best practice? We don't know. We honestly don't know. Well, we have some great studies that shows, for instance, methods like direct instruction having tremendous impact. If I ask my fellow former teacher colleagues, do you know about direct instruction? No one knows. 50% higher outcomes. So I think this is what, to me, lies ahead of us with competency-based education. Just we're trying something, we're learning forward. That there's really no way back from this. And thank you for having such an optimistic view on that. I love that. I also know that we are at the Q&A time, and I wanted to hand it back to Will at this point to see if we have any questions for
Yeah.
primarily Carol, I guess.
Yeah, thank you both. That was great discussion. I guess I do have a couple here for Carol, but actually just to start, Michael, we had some questions around the studies that you referenced, so specifically on confidence and self-efficacy. So if you could just repeat those for everyone on the call.
Yeah, so one that everyone actually should know about is David McClelland's work on achievement motivation. I can share a link that we could probably share alongside this. There's some excellent thinking. One of the biggest educational studies ever conducted since the World War II, showing that depending on what kind of baggage you carry, you sort of deem yourself differently. And basically it's Albert Bandura, who you think you are and what you think you can do will determine what you do and how well you do it. But I'm gonna add some links to this.
Okay, great. And then for Carol, we have a few. So the first one with is actually, it says many competency definitions include observable behaviors. What is your experience with defining competency criteria so it's measurable, and how do you establish the criteria so it's leveled for a learner?
So AACN is working on progression indicators and also simulation scenarios that we're going to actually have available for the nation to use. And so that work is emerging right now. So this ability, and I think that this is a really important piece of what you just asked, Will, is that when you go in to do a scenario in simulation, you actually are targeting multiple sub-competencies. So it's not like creating one and then doing that. We don't practice that way. We practice with a bunch of competencies coming together around what we're trying to do. So the metrics will vary according to your program objectives and what you're trying to accomplish. So that's why AACN suggested that everybody map their program to the competencies and then see where there are gaps, because we are doing some really good competency education. We might not have called that in the past, but I think we have to critically look at it and make sure that it is doing what we're doing, or do we need to up it up a little bit and make it a little bit stronger? So, so keep going back to the AACN website for the resources. They're not necessarily all there yet. We are in the process of beginning that work, but it is coming to be helpful, to be supportive. And if you have things you would like to share, you also can contact me and or the AACN and share your work so that others can benefit from that work as well. Because like I said, and like Michael said from the beginning, we don't have the how-tos. We really are trying to do the best we can. We just know that we can't stay where we were when we were having learners enter practice and not be ready, and then being frightened or concerned and leave. That's what we're trying to mitigate, to prepare them so they're able to stand fast and to do the hard work of caring for people.
Great, thank you. And I guess this one is more general to simulation itself. But what do you do with the student who can't get their head around the pretend concept of the scenario? And how do you make it more believable or real for them?
That is a wonderful question. And if you go to the Healthcare Standards of Best Practice from Anaxel, there's a one on pre-briefing. And the pre-briefing is how you set the stage for the learners. And so you'll always have occasional aberrant student, is what I call them, who doesn't buy in. But I think that they deserve a conversation on the sideline to help them understand. But you do have to situate in pre-brief that this is not real. We're not even pretending that it is real, but we're trying to mimic as best we can the clinical situation. But the patient scenarios often are real. And you will encounter these things when you're in your first year or second year of practice. So if you imagine that the content we're trying to help you pull together and manage is real, the methodology with which we do it is we give you the best realism we can, but in all honesty, we can't be in the clinical unit with a real live patient and train you and allow you to make mistakes. That's the realism. So we bring it back to a place that we can create a place for you to actually try and maybe fail and also come back and do again. So the realism, I think we have to situate it for them and ask them and invite them really to buy into it, that we know that we're not going to have all the realism that we want, but we're doing the best we can. But the bigger point is the content we're teaching and the thinking that you are doing, and your learning and your thinking is real. And that's what we're targeting.
And if I may add to that, so you used the word realism, but you could also use the word relevance. because you made a very important point. Students, dear students, you will meet this. So, and this is speaking to not their heads, but actually maybe deeper into them and say, when you get out there or when you come back from practice, you will have experiences relating to exactly what we're going to do today. So I think those two R's, realism and relevance, they sort of go hand in hand a bit.
And I think the other piece, Michael, is we're trying very hard to equip them to know what to do.
Yeah.
We want to, and if they understand that our intent is to equip them to rehearse what they might have to do when they are the nurse and they're the only nurse at the bedside at the moment. And we want them to be able to do the right thing at the right moment to make the most impact upon the patient and their family and the care that they do. When patients are in the hospital, it's just a moment in time in their life. It's a season, in essence. They had a huge life before they came. They have a huge life, hopefully, after they leave us. And they may not remember your name, but they will remember how you treated them as a nurse. And
Yes.
that reflects back to Maya Angelou's point about we remember how people treated us. So you want to know and do and be able to evaluate and adjust according to this individual in front of us. They're not a textbook. They have different nuances, and you want to be able to be fluid but exact with your expertise in order to help them have the optimal outcome for whatever situation they're in.
Great. Thank you. We have one more here. So where do you see simulation best fitting into competency-based education as a teaching modality, as an assessment strategy, etc.?
So I think that simulation is a methodology. And so it is not an end product in itself. And that's what your question is saying, is a methodology. And so what I want us to do is to recognize that we need it informative and summative ways. But we have to be careful not to make the summative punitive. We have to make sure the summative is actually also helping to advance the learner's thinking. So I would see it as an assessment and an opportunity to give feedback and maybe come back and redo. Michael said earlier on, and I wanted to touch on it, that he's seen people do a simulation and then debrief it and move on to the next simulation. We do not do a lot of going back and repeating that simulation and trying again. I think that's a window that we have closed too quickly. We should open it back up and allow our learners to go back in and be successful from what we just talked about in the debrief and bringing it back to trying it again. I think that would build confidence and competency in the way that we actually use simulation as a way to train.
Great. And then we got one more here. Sorry, we have a long list I'm sorting through here.
That's wonderful.
There are many thoughts about giving a grade in simulation. What are your thoughts and how do you feel about it?
For what reason is my question. We always have to ask that. For what reason would I do that? And so I would advocate not grading it. We actually don't grade our students in their simulations, but rather grade other components like their reflection or their engagement in the activity. Really looking at it from a point of view, but not actually their performance in the simulation, because in the performance, if we're using it formatively, if I know you're grading me, I'm not going to reveal to you the things I don't know. I'm going to hide them from you because you're grading me. And we really want them to reveal to us the gaps that they have so that we can fill those in before they actually get into practice. So I think you have to be somewhat deliberate about when you want to make it a summative evaluation versus formative. And I think there needs to be a lot of formative, a lot of coaching, a lot of building of skills before we move to summative simulations. And there's probably going to be a place for those, but I think we need to be judicious in the way that we use them and not be harming the learner by slamming them too much with you didn't meet the mark, when in fact we need to, like we talked about earlier, we're going to have learners along the continuum. Are they all valuable and capable of becoming a nurse? Yes. Can we help them do that? I think that's what we want to do.
And you're making extremely important point, because in education, our job is to take someone from 0 to 100 in a way, to put it simply, right? And we are not only accepting, but we are expecting suboptimal performance all the way up until we deem them competent at whatever time. And that changes Monday morning when they meet at work in a hospital, because all of a sudden they cannot fall below a certain level,
Right.
because then you're dangerous. So let's education is about helping them move upwards, not to sort of slam a mark in their face necessarily. That said, I also need to understand, where am I on this continuum?
Yes, absolutely.
So somehow there's a give and take here. I need to understand, where am I right now on the continuum on this particular competence?
And where am I in terms of meeting the designated evidence-based benchmark of what it should be, right? And so it is not, we cannot also give false reassurance like we wouldn't to a patient that you're doing great, when in fact you're meeting these metrics and we need for you to meet these metrics, and I see you're making progress. So we're really talking about a continuum of learning. You're moving along, progressing, developing the competencies is what we're after. And so not just one day you're not competent and next day you are. You're developing competencies is what we're trying to get you to do. And so I think that's a mindset change for us as educators as well. The coaching and developing of competencies is kind of a different way to think about it.
Mm.
You know, in nursing, the very first day that you're a nurse, you will do certain things. And the very last day that you practice nursing before you retire, you will be doing many of those very same things. Putting on gloves, assessing patients, intervening, reassuring, providing quality care. So it's a continuum, and you will progress in your skill and expertise across your career. And I think that we need to have our learners understand, not only do we hope for and expect a growth mindset from them, but also demonstrate that we don't know everything, and we too have a growth mindset, and I'm now curious about the thing I don't know either, and I model how to go find that out.
Great, thank you, Carol. And I know we're just about at time here, but just one more quick question, and I think this actually will pertain very closely to your work. Is there a way to get involved in helping align the simulation scenarios with the AACN essentials and competencies?
Please do send me an email if you're curious about that, and say in the subject line AACN simulation or something. I get over 100 emails, it seems like, in the morning and then again in the afternoon. So if you could make sure I could find you, or if you want to do it through Will and Laerdal team, then they can actually compile a list and send it to me. That would be lovely.
That's great. Thank you. Yep. Feel free to reach out to myself as well. And I think that's it. So first of all, I wanted to say thank you to both of you. I think we're going to wrap this up now. So Rebecca, I think we have one or two more slides here. So yes, just wanted to remind everyone that our Laerdal Medical National Sun is October 28th through the 30th in Las Vegas, Nevada. Our breakout session speaker call for speakers is now open, and pre-registering is now open as well. So please use that QR code on the screen to scan for that. And then one more QR code here is a little bit more about Laerdal's CBE solutions. So this QR code will actually take you to a page that gives a little oversight as far as some products that could help you in your CBE journey. But that's about it. Thank you, everyone. This was a great webinar. Especially thank you to Carol and Michael, and we will talk to you soon.